لتشريفه تشيرمان معانا، يعني شرف لينا في الجلسة، والأستاذ الدكتور أيمن أسامة شرف كبير لينا، والأستاذ الدكتور وليد من الأردن الشقيق. احنا تشرفنا بحضرتك جامد. سكند الأستاذ الدكتور محمد علي، أستاذ الأشعة في القصر العيني.
بسم الله الرحمن الرحيم. CT derived fractional flow reserve, a promising diagnostic tool in assessment of myocardial ischemia, an initial Egyptian experience. أول حاجة الراشونال of FFR. Ischemic chest pain is a common clinical presentation that often requires assessment using non-invasive and invasive tests. The goal of testing is to document the presence or absence of coronary artery disease and myocardial ischemia, and to direct subsequent treatment. Invasive coronary angiography is the established standard for evaluation of coronary artery disease. However, the correlation between the angiographic stenosis and the myocardial ischemia is limited. Current guidelines for management of stable coronary artery disease recommend documenting ischemia using a non-invasive functional test. These include myocardial perfusion imaging, stress echocardiography, and cardiac magnetic resonance. The assessment of myocardial ischemia could be either non-invasive or invasive. The non-invasive tools include stress ECG, stress echo, stress perfusion CMR, stress perfusion CT, and the SPECT. And the SPECT is the mostly widely used nowadays for assessment of myocardial ischemia. The invasive assessment is the catheter-based FFR. The catheter-based FFR is the gold standard technique for evaluation of the lesion-related ischemia. FFR is a ratio between the maximum flow across a stenotic lesion to the presumed flow in absence of stenosis. Myocardial perfusion imaging traditionally has been the cornerstone for non-invasive diagnosis of myocardial ischemia. However, it has its limitations regarding the limited spatial resolution and the absence of detailed anatomical information about the coronary anatomy and the presence of coronary artery disease. On the other hand, CT coronary angiography is increasingly used as a diagnostic tool for detecting coronary artery disease. It has a high sensitivity and high negative predictive value. This means the absence of coronary stenosis in a good quality CT angiography study is associated with excellent prognosis and obviates the need for further evaluation. However, the CT coronary angiography also has its limitations, including the false positive results and the limited correlation between the stenotic lesion and the downstream myocardial ischemia. The false positive results are usually due to dense calcifications and cardiac motion artifacts, and evaluation of coronary artery disease based on coronary CT angiography had increased the rate of invasive coronary angiography by almost 50%. Invasive fractional flow reserve is the ratio of maximum myocardial blood flow across stenosis to the presumed blood flow in absence of stenosis. It depends on the measurement of pressure distal to the lesion and proximal to the region at maximum hyperemia. And it is considered the gold standard technique for detection of lesion-specific myocardial ischemia. Several randomized trials have shown that the FFR threshold is 0.8 or 0.75. In all cases with flow reduction below 0.5%, below 70% of the flow limitation means myocardial ischemia. Above 80% flow means can exclude ischemia, and there is a gray zone between 0.7 and 0.75 and 0.8. CT-derived fractional flow reserve is a non-invasive imaging post-prosthetic technique that enables the determination of hemodynamic significance of coronary stenotic lesions using data acquisition from the standard routine diagnostic CT coronary angiography without any modification regarding the protocol or additional acquisition or administration of medications or contrast. It is a simulation technique that uses computational flow dynamics to calculate the coronary blood flow across the lesion. It augments the CT ability to identify lesions that causes ischemia as compared to the only anatomical diagnosis derived from the CT angiography. The images are displayed in color as you see. Segments with high flow above 0.8 are tagged by blue, and when with reduction of the flow across the scale, we can reach to the red color. The CT-derived FFR offers several potential advantages, including high spatial resolution of the original CT angiographic study, which provide the anatomical data. In addition, the FFR adds the functional data with ability to identify the lesions causing ischemia. It's useful test to improve the diagnostic accuracy of CT angiography and to differentiate lesions and individuals who will benefit from revascularization. As you can see here, FFR has had significantly increased the specificity and positive predictive value of conventional CT angiography because of reduction of the false positive results. CT-derived FFR requires premium quality CT coronary angiography to be processed, no cardiac motion artifacts, no respiratory motion artifacts, and best contrast resolution, and also requires that all coronary segments should be perfectly delineated in a single phase of the cardiac cycle. The limitations of CT-derived FFR are the limitations of general limitations regarding the CT angiography of the coronary arteries, including the arrhythmias and persistently high heart rate, unstable clinical condition, and impaired renal function, the allergy to iodinated contrast, morbid obesity, and pregnancy. And there are some limitations for the FFR itself, including the severe left main disease, stenosis at the coronary ostium, and the complex bifurcation lesions. Regarding the first 2 points, there will not be a reference to correlate the flow distal and proximal to the site of the lesion. Also, in cases of chronic total occlusion, لأن في الحالات دي there is no need for FFR, there is flow limitation definitely. And in cases of prior coronary intervention أو bypass graft علشان الهيموداينامكس بتاعت الcoronary arteries بتختلف في حالات السيفير diffuse disease, الانيوريزم and coronary anomalies. كل دول بيغيروا في الفلو داينامكس بتاعت الكوروناري ارتريز، فما بينفعش ان احنا نعمل معاها FFR. I will show some representative cases performed here in Egypt. Case number 1 is a patient with a smoker and positive family history. The scintigraphy was negative, and this is the CT angiography study showing perfectly normal coronary arteries, and the FFR was also normal. In the second case, the patient was diabetic and dyslipidemic with negative scintigraphy. And here is the CT angiography. It appears normal, but in the FFR, the distal segment of the RCA show flow limitation. والحالة دي الهدف منها ان احنا نعرضها علشان اعرف حضراتكم ان احنا السبب الفلو ليميتيشن هو ان احنا عندنا في الديستال سيجمنت اوف ذا ار سي اي في موشن ارتيفاكتس. فاحنا لو استخدمنا الاف اف ار في حاله ما هياش برايمم كواليتي سي تي اي او الفيسلز مش باينه كويس كلها في نفس الفيز، ممكن تبقى النتيجه فولس بوزيتيف في الاف اف ار، فدي تقلل شويه السنسيتيفيتي بتاعه السي تي انجيوجرافي. فعشان كده احنا ما بنلجأ لهاش الا اذا كانت الفحص اوف برايمم كواليتي في السي تي. الحاله دي برضو عيان كان ديسليبيديميك والسي تي كوروناري مبين انه عنده نون اوبستراكتيف كوروناري ارتري اثيروسكليروتيك نون اوبستراكتيف كوروناري ارتري ديزيز. كان عنده بروكسيمال ال اي دي اكسنتريك ليجن مودريت about 40-50% stenosis, otherwise no significant stenotic lesions, and the FFR revealed normal flow across the left anterior descending artery, and this excludes the hemodynamic significant the ischemia the ischemic sequelae of this lesion, and this goes with the scintigraphy which that was negative for myocardial ischemia. In this case, the patient was dyslipidemic and the scintigraphy was performed only at rest and was negative. The patient has mild lesions in the left main trunk, LED and LCX arteries, but in the RCA there was a densely calcified lesion apparently causing moderate stenosis. One of the limitations of the CT angiography is the assessment of densely calcified lesion, and it was reported as moderate lesion. The FFR aided for proper diagnosis and revealed there is no significant flow limitation at the distal segment of the RCA or its terminal branches. Distal to the site of the lesion, the FFR was 0.9, and this indicates proper flow or adequate flow. In this case, there was a moderate to severely stenotic lesion at the proximal segment of the LAD, and the FFR was performed to assess if it causes ischemia or not. The FFR revealed distal flow limitation at the mid or distal segment of the LAD. The FFR was 0.75, and this indicates that there is a flow limitation of the LAD distal to the site of lesion, which was reported as a moderate to severely stenotic lesion. But in the scintigraphy, the scintigraphy was negative and no ischemia. السبب القصه دي ودي النقطه الاخيره اللي عايزين نشير اليها، ان هو اغلب البيبرز اللي اتنشرت على الفاليديتي بتاعت الاف اف ار كانت بتقارن الاف اف ار بالسبكت على اساس انها الاثنين بيأسس مايوكارديال برفيوجن، وفي الحقيقه ده مش ده الموقف، وده سبب الاختلاف اللي حصل ده، ان الاف اف ار بيأسس الفلو في الديستال سيجمنت اوف ذا ارتري، بينما السبكت بيأسس المايوكارديال برفيوجن، والاثنين غير بعض. العيان ده لو عنده كولاترالز كويسه هيبقى فيه فلو ليميتيشن في الديستال سيجمنت اوف ذا ال اي تي ومفيش مايوكارديال برفيوجن، فعشان كده ده ممكن يفسر ان السبكت طلع نيجاتيف وان الاف اف ار طلع بوزيتيف في نفس العيان، هم ممكن يكون الاثنين قرايتين صح. And finally, the take-home message is the CT angiography has a high diagnostic accuracy for anatomical stenosis, but cannot determine the physiological significance of the lesion. Assessment of lesion-specific ischemia is important before revascularization. Invasive catheter-based FFR is the gold standard for diagnosis of lesion-specific ischemia. CT-derived FFR allows non-invasive assessment of lesion-specific ischemia in high-quality exams, but its cost effectiveness is still doubtful. Thank you.